What I'd like to discuss today is how we can improve the anesthetic care that we provide to patients undergoing complex spine surgery, and more specifically, how regional anesthesia may be able to contribute to this. I'll start by providing an overview of the major considerations in complex spine surgery, then discuss the important elements of anesthetic care that may contribute to enhanced recovery. And to end, I'll review the role for regional anesthesia techniques and the evidence that we have currently for their impact in the context of spine surgery. Now, spine surgery is an extremely heterogeneous set of procedures with very different pathologies, patient characteristics, surgical techniques, and thus considerations. One practical way to classify it is by anatomical region: cervical, thoracic, and lumbar, with lumbar being the most common of the three. And this is particularly useful when we think about targets for regional anesthesia, as we will see. It's also important, though, to consider the surgical pathology and the type of surgery being performed. And this is by no means an exhaustive list, but broadly speaking, we have prolapsed intervertebral discs, spinal stenosis, spinal deformity, and cancer, either primary or metastatic. Procedures include disectomies, bony decompressions, fusion, deformity correction, tumor resection, or some combination of all of these. The number of vertebral levels involved is a commonly used indicator of the degree of surgical insult, and thus the anticipated course of recovery. The use of minimally invasive surgical techniques where appropriate will also influence pain and functional recovery. It's therefore challenging to define a one-size-fits-all pathway of optimal clinical care for spine surgery. And it's only fairly recently that the concept of developing ERAS pathways or enhanced recovery pathways in spine surgery have begun to emerge. And it's becoming clear that at a minimum, we need to make these specific to different surgical procedures in different anatomical locations. Now, here is one example of an ERAS pathway for spine surgery that spans the preoperative, intraoperative, and postoperative periods. You can see that in reality, the scope of our anesthetic interventions is limited to just a small part of the pathway, and thus we should temper our expectations of their impact on patient outcomes. Nevertheless, there are certain common anesthetic goals and considerations that we need to pay attention to. These include anticipating and minimizing blood loss and transfusion, preventing iatrogenic damage to neural structures, providing adequate opioid-sparing analgesia with a view to encouraging early return of oral intake and gastrointestinal function, mobilization and ambulation, and hopefully expediting discharge from hospital. Now, longer-term functional outcomes include prevention of chronic pain and opioid dependence, independence in activities of daily living, and improvement in measures of disability. Although I think these are just as important, trying to influence these with anesthetic interventions is probably wishful thinking, given the big discrepancy in the time frames. As a result, most of the anesthetic interventions studied to date have to do with just trying to provide good postoperative pain control while minimizing opioid requirements. And the multimodal analgesic approach is logical, with preemptive interventions where possible, and elements of this are included in almost all the described ERAS pathways. Certain common elements are listed here, most of which are supported by evidence, albeit of varying quality and sometimes extrapolated from other clinical scenarios. But what's critical, in my opinion, is that our interventions need to span the preoperative and early postoperative period as much as possible, not just the intraoperative period. Just focusing on that intraoperative phase, as I will show you, is likely to have little impact. I'd like to comment on two things. First, the use of NSAIDs, which remains controversial in spine surgery mainly due to concerns regarding an increased risk of bleeding and an increase in the risk of delayed bony healing and the incidence of malunion or non-union. However, the risk of bleeding has not been shown to be increased by the use of ketorolac and is likely to be even lower with COX-2 specific inhibitors. And the most recent data suggests that the risk of clinically significant delayed bony healing is likely to also be insignificant if we use short courses of NSAIDs in appropriate doses. And the majority of our own surgeons at the Toronto Western Hospital have in recent years embraced the use of NSAIDs for up to 48 to 72 hours so as to minimize opioid use. And NSAIDs are particularly valuable because a large contribution of postoperative pain in spine surgery is from muscular trauma and spasm, secondary to incisions, but also from stretch that occurs even with MIS techniques. And this brings me to a second point, which is that muscle relaxants such as cyclobenzaprine, methylcarbamol, baclofen, and even diazepam may be valuable adjuncts to patient comfort. They're probably underutilized, partly from a lack of awareness, but also valid concerns regarding sedation. Nevertheless, I think they should be kept in mind for when we have significant paraspinal muscular spasm in our patients. But we now have another option for relieving musculoskeletal pain associated with spine surgery, and that is to block the nerves innervating the vertebrae and paraspinal muscles with local anesthetic, using ultrasound-guided fascial plane blocks. The dorsal rami of the spinal nerves, which branch off each spinal nerve root close to where they emerge from the intervertebral foramen, innervate the bony spine and the paraspinal muscles as well as overlying skin. And these are easily targeted by paraspinal blocks such as the ESP and TLIP blocks. And multiple levels, usually at least 3 to 4, can be covered from a single injection point as local anesthetic spreads within the fascial plane. And this is one of the major advantages over local anesthetic infiltration by surgeons at closure, which can be haphazard and inconsistent depending on who's doing it. Now, it's worth noting that with the ESP or erector spinae plane block, some local anesthetic does penetrate into the paravertebral space where it acts on the spinal nerve near the intervertebral foramen. And this is what accounts for a blockade of afferents from ventral rami. If performing lumbar ESPs for lumbar spine surgery, therefore, this is something to bear in mind, although as I will talk about, it is rarely clinically apparent. So as I've said, there are two main techniques for posterior spine surgery: the erector spinae plane or ESP block and the thoracolumbar interfascial plane or TLIP block. I will spend most of my time discussing these, but before I go there, I want to mention two other regional anesthesia blocks that can be used for anterior approaches to spine surgery. The first is to perform a superficial cervical plexus block to improve analgesia in anterior cervical decompression and fusion surgery. Our surgeons now routinely perform this using a landmark-guided technique, but it can also be done under ultrasound guidance, which may improve accuracy. A 2017 RCT has also compared cervical plexus blocks to general anesthesia for ACDFs, and while they showed it was feasible, there were no real advantages. Patients actually reported some intraoperative discomfort and, perhaps not surprisingly, lower satisfaction. Transversus abdominis plane or TAP blocks and other abdominal wall blocks can also be used to augment analgesia for anterior approaches to the lumbar spine that involve an anterolateral abdominal incision. I personally have no experience with this, but there are a couple of retrospective comparative studies that report favorable results on analgesia and shortened length of stay. Returning to the ESP and TLIP blocks, won't spend a lot of time on the technical details, which I've described elsewhere in videos that are freely available on YouTube. But essentially, in the ESP block, we deposit local anesthetic in the fascial plane between the erector spinae muscles and the transverse processes. This spreads to several vertebral levels in the cranial and caudal direction and effectively blocks the branches of the dorsal rami as they traverse this plane. ESP blocks can be done at any level in the thoracic and lumbar spine to cover the requisite areas. The TLIP or TLIP block, on the other hand, is specific to the lumbar spine, and the injection is performed into a more superficial location, in the fascial plane between multifidus muscle and the longissimus thoracis muscle. Local anesthetic will, again, spread in a craniocaudal direction along this plane. It usually covers at least 2 to 3 levels. A modified TLIP block has also been described in which injection is performed into the plane between longissimus and iliocostalis, more laterally. It's supposedly technically easier to perform, but I would say that this is a matter of experience and personal preference. Note that ESP and TLIP blocks must be performed bilaterally for adequate coverage. A 20 ml volume in adults is usually injected on each side using a long-acting local anesthetic like ropivacaine or bupivacaine, and the concentration should be adjusted to stay within maximum recommended dose limits for the drug. I also recommend always adding 5 mics per mil of epinephrine to reduce systemic absorption and the risk of local anesthetic systemic toxicity. Last is the main potential risk with these techniques, but even that risk appears to be very low. These are otherwise very safe blocks. There are no discrete nerves or blood vessels at risk of mechanical injury from the needle or compression from any hematomas that might form. In this retrospective review of 342 patients from the Hospital for Special Surgery in New York, there were no observed complications attributable to the lumbar ESP blocks. They also noted no interference with intraoperative neuromonitoring or postoperative neurological examination. However, with ESP blocks, local anesthetic can potentially spread to the epidural space or lumbar nerve roots, which may in turn produce blockade of the ventral rami, resulting in motor or sensory block of the lower limbs. Clinically evident blockade of this nature is, however, rarely observed. If you are concerned, it's been suggested that the TLIP blocks may carry a lower risk since local anesthetic is injected further away from the main nerve root, and it may be one reason to consider it over the ESP block in the lumbar spine. I also think that the TLIP block is easier to perform in patients with deep transverse processes, something we see a lot of in the Western Hemisphere compared to Asia. I have discussed the considerations in choosing between the two in depth in another talk, again available on YouTube. There is a ton of literature on the use of ESP blocks in spine surgery now, and to a lesser extent, TLIP blocks as well. This includes a large number of RCTs, almost all in lumbar spine surgery. Now, most of these are in fairly straightforward operations, that is, discectomies, 1 to 2 level decompressions and fusions, vertebral fractures, and minimally invasive approaches. There's less literature for thoracic spine specifically, but speaking from personal experience, it's just as feasible to perform. Turning to the literature on lumbar spine surgery, however, the findings are pretty consistent for both ESP blocks and TLIP blocks. The feasibility of the techniques is clear, with most studies performing it after induction of general anesthesia and after surgical positioning in the prone position. I personally find, though, that if you have the space and the time to do them ahead of induction, this is preferable, as the increased time for block onset before surgical incision allows for complete anesthesia to set in. Now, all the studies have shown statistically significant and arguably clinically significant reductions in pain scores over at least the first 12 to 14 hours, consistent with the anticipated durations of the block. And there are reductions in cumulative opioid and rescue analgesic requirements for up to 24 hours. This is accompanied by large reductions in opioid-associated adverse effects such as pruritus and, more importantly, nausea and vomiting, even in the presence of antiemetic therapy. Patients are able to mobilize earlier, probably related to reductions in pain on movement, not just at rest, and overall there is higher patient satisfaction with the administration of these blocks. This study out of Dublin also found a 13-point difference in quality of recovery 15 scores, which exceeds the minimum clinically important difference of 8. I've also listed here the individual elements where significant differences were found on a 0 to 10 scale. I think you'll agree that all of these are important and meaningful patient-centered outcomes, especially this one, and all of them are clearly impacted by the quality of analgesia. Finally, it's important to note that several studies have also shown now that preoperative ESP and TLIP blocks are superior to postoperative surgical wound infiltration, generally providing better analgesia that has a longer duration. There may be two reasons for this. First, there may be a preemptive benefit to pre-incisional regional anesthesia. And second, it's likely that ultrasound-guided fascial plane injections provide a more consistent coverage of the relevant areas, whereas surgical infiltration can be highly operator-dependent. Now, it must be said that the clinical impact of these differences in outcomes have been questioned, most notably in this recent study by Soffin and colleagues at the Hospital for Special Surgery. It's worth noting that they are leaders in this area and have been early champions of paraspinal blocks in this context. And although the conclusions are rather pessimistic at first glance, I think there are a couple of important things to note. First of all, the ESP blocks were added on top of what was already a comprehensive pathway-based care protocol, with modalities that other institutions might not routinely incorporate. Second, the majority of patients did not have risk factors for severe postoperative pain. Despite this, ESP blocks still produced a detectable positive difference in important outcomes. Whether or not you consider the magnitude of these differences meaningful is to some extent subjective. In fact, I'd say it's probably as subjective as the choice between flying business or economy class. Both of them will get you to your destination, but at different levels of comfort. And the question is, how important is this degree of comfort to you or your patient, and is the price worth it? And perhaps, in the case of the hospital for special surgery pathway, adding ESP blocks is like flying first class versus business class. The benefits are indeed more marginal. However, we also have to ask ourselves, what's the price differential? The price of regional anesthesia can be measured in effort and expertise required, time required to perform the block, complications and side effects. And I think that paraspinal blocks represent a bargain in this respect. This problem of demonstrating clinically meaningful outcomes is not confined to regional anesthesia blocks alone. In this placebo-controlled study from the Cleveland Clinic, they specifically studied patients having complex multi-level spine surgery with 2 or more risk factors for severe postoperative pain, and they looked at whether an intraoperative multimodal anesthetic regimen would reduce pain and improve outcomes. There were 4 components in the intervention group: preoperative acetaminophen 1 gram and gabapentin 600 milligrams, a lidocaine infusion that was continued until 1 hour into the PACU stay, and a ketamine infusion that was continued until wound closure. The control group had placebo treatments, and both groups received a volatile-based anesthetic and an intraoperative opioid infusion. Now, the investigators chose quality of recovery at 72 hours as their primary endpoint, which is quite a long way out from the intraoperative anesthetic period. And so perhaps unsurprisingly, there was no difference between groups. However, it's worth noting that there were also no differences in 24-hour or 48-hour opioid consumption and pain scores. So what do we make of this? Well, I think that in patients who have pre-existing chronic pain issues, who are at high risk of severe postoperative pain, and who are undergoing more extensive and complex surgery, it's really difficult to completely abolish or attenuate postoperative pain no matter what you do. In addition, if we start to consider outcomes beyond 24 and 48 hours, then significant differences are going to be hard to demonstrate, given the limited duration of our intraoperative interventions. I still think, though, that there is value to a multimodal anesthetic approach, and it could be that we have not yet identified the most effective possible combination of modalities. More importantly, our intraoperative interventions, including blocks, must be part of a larger postoperative care pathway. The principle of preventative opioid-sparing analgesia is get our patients off to a good start, but then we must try and keep them there. Is it possible to extend the duration of our regional anesthesia blocks? There are options, but I will say not a lot of strong evidence for any of them as yet. Local anesthetic additives such as dexamethasone and dexmedetomidine are probably the easiest to administer, and they have been shown to prolong analgesia of peripheral nerve blocks in other settings. In this case, since we're not depositing local anesthetic directly around the nerves, I think that it's reasonable to administer intravenous dexamethasone and dexmedetomidine intraoperatively rather than mixing them into the local anesthetic solution. Liposomal bupivacaine has also been reported in some studies, although the benefits are still unclear and must be weighed against the expense. Catheters and continuous local anesthetic infusion or intermittent boluses have been used, but there are logistical issues. Preoperative insertion requires that there is some distance from the surgical field, which may limit their efficacy. Ultrasound-guided postoperative insertion is generally not feasible, as the tissue planes will now have been disrupted. However, our surgical colleagues could place catheters at the time of closure, and this again has been recently described by the group at Hospital for Special Surgery in a small proof-of-concept pilot study. They initiated infusions at the end of surgery with a small loading bolus of 10 mL on each side and maintained them for 48 hours. The takeaway was that it appears a feasible technique, but the efficacy was only comparable to single injection preoperative ESP blocks, not superior in this small study. And patients still required some amount of opioids, so the blocks were not producing complete analgesia. Therefore, it's a technique that holds some promise, but some more work is clearly needed to establish how useful it will be. Now, we've not yet seen much work on paraspinal blocks for cervical spine surgery. Various blocks targeting fascial planes between the cervical paraspinal muscles have been described, chiefly by Japanese researchers, but systematic investigation is still awaited. Understanding the anatomy and the targets for injection also requires a little bit of thought and study, as these are not immediately familiar to most of us who are not chronic pain physicians. On the other hand, ESP blocks at the T1 level are an option. Here we would target the T1 transverse process as usual and use a caudal to cranial direction of injection. And this was recently studied in an RCT on posterior cervical spine surgery. Similar to the results of lumbar ESP blocks, patients who received the T1 ESP blocks had lower pain scores and lower cumulative opiate requirements over 48 hours, less nausea and vomiting, and lower sedation scores in the first 12 hours. They also sat up and walked earlier than patients in the control group. I'd like to leave you with the following points to consider. Spine surgery is a heterogeneous group of procedures, and at a minimum, anesthetic strategies and protocols must be tailored to the site, cervical, thoracic, or lumbar, but also to the specifics of the procedure itself. The patients are similarly heterogeneous, ranging from relatively young and healthy to patients with chronic pain, opioid use, and long-standing disability and physical deconditioning. The pain trajectory and recovery profile for each of these patients will be dramatically different. Now, almost all of our anesthetic interventions will have a fixed and finite duration of action, and thus any impact is realistically only going to be on short-term outcomes. And the magnitude of this benefit, as we've seen, can be of debatable significance. However, this does not mean that it is not worth doing, especially if the downside is limited. As I've said, with regional anesthesia blocks for spine surgery, the main constraints are the time and effort required to perform them. As fascial plane blocks, they are very safe, so the benefit-risk ratio is favorable in my opinion. Ultimately, I do believe there's value in a multimodal anesthetic approach, ideally incorporated into a larger ERAS pathway. And care needs to be tailored to the specific patient population, but where possible also to the individual patient. It's similarly vital to take your local context into account, which means the resources that you have at your disposal and the team that you work with, not only surgeons, but also nurses, physiotherapists, and other healthcare providers. We can't expect any single intervention to change things, but regional anesthesia techniques are an additional arrow in our quiver for reducing intraoperative and immediate postoperative pain and opiate requirements, and I think they are a significant step forward. As other authors have pointed out, there is great promise in these techniques, and I personally am looking forward to more well-designed and appropriately powered studies in the appropriately specific surgical cohorts. Here are some resources if you want more information. The QR codes linked to the YouTube videos. But I also highly recommend this excellent review article by McCracken and colleagues, which was just published.